Hello, my name is Julio Lamprea-Montealegre. I'm a clinical instructor in the Division of Cardiology at the University of California, San Francisco, and a postdoctoral scholar at the Center for Aging in Diverse Communities at UCSF. Today, I will be presenting the research that I've been doing for the past year at the CADC. The objectives of this research were to assess whether racial and ethnic healthcare disparities exist for the prescription of cardiac and kidney protective therapies in the VA healthcare system during 2019 and 2020 among patients with type 2 diabetes. During the past 2 years, all major scientific guidelines for the treatment and prevention of diabetes have added a fourth pillar for the management of type 2 diabetes. Medications with evidence of cardiac and kidney protection should be prioritized. Specifically, two classes of medications should be prioritized: the sodium glucose cotransporter 2 inhibitors and the glucagon-like receptor 1 agonists. These recommendations respond to research during the past decade, which have consistently shown cardiac and kidney protective effects. For SGLT2 inhibitors, this started with the EMPA-REG study, and for GLP-1 receptor agonist with the LEADER trial. Taken together, SGLT2 and GLP-1 receptor agonists are associated with 20 to 30% relative risk reduction in major cardiovascular events and 30 to 40% relative risk reduction in CKD progression, including progression to dialysis. Because these are medications that can substantially lower the risk of major adverse consequences of diabetes, there is an urgent need for their rapid implementation. The current recommendation, which is endorsed by the American Diabetes Association and by all other major scientific guidelines, is that all patients with type 2 diabetes and concomitant heart failure, atherosclerotic cardiovascular disease, or chronic kidney disease should be on a GLP-1 receptor agonist, an SGLT2 inhibitor, or in both medications, irrespective of glycemic control. Despite these recommendations, we know that there is a major treatment gap in the implementation of these medications. Currently, less than 10% of patients with type 2 diabetes are on these medications. Patients with concomitant heart failure, atherosclerotic cardiovascular disease, and chronic kidney disease, that is, the three conditions for which prescription needs to be prioritized, are less likely to be prescribed these medications. More recent research has shown that compared to white patients, racial and ethnic minority groups are less likely to be prescribed these therapies. However, these studies were conducted using data from commercial and Medicare plans. The fact that the prescription was found to be strongly influenced by patients' income may have influenced the results, since the patient cost sharing for these medications can be substantial. In contrast to this, the VA system provides an ideal setting to explore racial and ethnic disparities in medication prescriptions, since it provides uniform pharmacy benefits with minimal or no patient cost sharing. Therefore, the main objective of this research is to explore racial and ethnic differences in the prescription of SGLT2 inhibitors and GLP-1 receptor agonists in the VA healthcare system. Using the VA data, the VA Extensive Electronic Healthcare Record Information Network, we identified more than 5 million patients nationally with at least one primary care provider clinic visit during the period of 2019 through 2020. Among these patients, we selected those with the diagnosis of type 2 diabetes. We excluded patients with end-stage kidney disease, post-kidney transplants, and patients receiving hospice care. After exclusions, the study sample consisted of more than 1.3 million patients with type 2 diabetes, of which 10% were on an SGLT2 inhibitor and 7% were on a GLP-1 receptor agonist. This table shows the main demographic and clinical characteristics of the study sample by race group. Briefly, compared to other racial groups, white patients were substantially older. Compared to other racial groups, Black patients were less likely to self-identify as having Hispanic or Latinx ethnicity. Black patients were most likely to have a service-connected disability greater than 50%, and white patients for having diagnosis of diabetes related to their service connection. In the VA system, this is important since these two groups of patients do not have any co-payments for their medications. Black and American Indian patients, compared to other racial groups, were more likely to be in the lowest zip code median income quartile or to be in the highest social deprivation index. Finally, white patients were more likely to have a concomitant diagnosis of atherosclerotic cardiovascular disease, heart failure, and chronic kidney disease. This table shows the multivariable association of race and ethnicity groups with prescription of SGLT2 inhibitors on the left and GLP-1 receptor agonists on the right. These models are multivariable logistic regression models which adjusted for demographic factors, socioeconomic characteristics, co-payment for medications, comorbidities, frailty, prescribing facility, the prescribing facility complexity level, and geographic location. In general, all racial groups compared to white patients were less likely to be prescribed these medications. In particular, compared to white patients, Black patients had 24% lower odds of prescription of SGLT2 inhibitors and 32% lower odds for prescriptions of GLP-1 receptor agonists. We attempted to understand these disparities a little bit better by building sequential adjustment models, which are shown in this figure. In model 1, we adjust for demographic characteristics. In model 2, we adjust for variables in model 1 and patient, clinical, and socioeconomic characteristics. And then in model 3, we adjust for variables in model 1 and model 2 and facility characteristics, including the facility, the prescribing facility complexity level, and the geographic location. The lower prescription for SGLT2 inhibitors, and in particular, among Black patients compared to whites, were observed across all models. The same pattern was observed for GLP-1 receptor agonists, whereby compared to white patients, Black patients were substantially less likely to be prescribed these medications across all three models. Finally, because the models that I showed are cross-sectional analysis that combine patients with prevalent and incident prescription of these medications, we conducted sensitivity analysis that assessed trends in the new prescription for SGLT2 inhibitors and GLP-1 from 2017 to 2021. This analysis showed that for all racial groups, prescription has been increasing with time, but disparities in prescription persist, with Black patients being less likely to be prescribed these medications. In conclusion, compared to white patients, we found that patients of racial and ethnic minority groups, and in particular, Black patients, were less likely to be prescribed SGLT2 inhibitors and GLP-1 receptor agonists, accounting for individual, facility, and geographic level characteristics. As it is likely that the quality improvement initiatives will be implemented to overcome the current treatment gap, our findings suggest that such initiatives must take a racial and ethnic equity lens, so improvements in care extend benefits to all. I want to thank Dr. Leah Carliner, who's been my mentor at the CADC, Also, Dr. Todd Netlands, who's provided great statistical advice, Drs. Michael Schlipak and Michelle Estrella, who are my wonderful primary research mentors at UCSF, and Ms. Erin Madden, who is the main collaborator in this research. And of course, to all the CADC faculty and fellow scholars. Thank you very much.